Our next speaker is Lipalo Mokete, also well known to all of us, and Lipalo is going to speak to us on tibial periprosthetic fractures.
Thank you very much, Mr. Chairman, and good morning, ladies and gentlemen. So I'll continue along the same theme, talking about periprosthetic fractures affecting the tibia and a total knee replacement. So periprosthetic fractures, if you talk about periprosthetic fractures around a total knee replacement in general, Prof. Van der Jacht has already told us about these fractures, that they affect about 2.5% of total knee replacements and up to 35% in revision total knee replacements. That is looking at intraoperative fractures as well. And they are difficult fractures to deal with. You get 41% complications in the treatment of these fractures, and a lot of those cases, so up to 29% of those cases will need to be re-revised. So this is a difficult problem to deal with. With periprosthetic fractures around a total knee replacement, they are much more common in the femur than the tibia. So 4% of them will be in the tibia. And a large number of these, 19%, will be as a consequence of intraoperative implantation of the prosthesis. The risk factors, we've heard about the risk factors already, but I'd like to draw you to this here. So component looseness. So this aspect here takes far more importance with the tibia as opposed to any of the others that we've dealt with thus far. And also, if you look at component malalignment, there's probably a suggestion that that tibia that is in marked varus is the one that is likely to lead to a fracture, although there isn't really concrete proof of this, but there is a suggestion that that may well be the case. So it is important to align your components correctly at the time of surgery. The diagnosis, so there may be a history of trauma. We may know that the prosthesis is loose. These patients are old patients. They have comorbidities. When you examine the patient, there may be deformity, there may be tenderness. And in terms of x-rays, standard AP and lateral x-rays are sufficient. Sometimes, as the Prof. Van der Jacht has indicated, an oblique x-ray may also be very important to delineate the fracture. CT scan is helpful, not always necessary, but certainly you have to have the metal artifact suppression protocol on the CT scan for you to be able to gain that additional information. So the questions that you would want to know is, number one, is the prosthesis loose? And then you also want to be able to look at the fracture pattern. So this is again where the CT scan comes into its own, because it can help you delineate the exact fracture pattern so that you can plan your management properly. It is important in these cases to exclude infection. It's not always easy. From the history, so if the index operation was 10, 15 years before the failure of the prosthesis, then it's likely that there is an infection. But if it's within 18 months, then the possibility of infection is pretty high. And the ESR and CRP, these are the investigations that we normally use to be able to indicate whether there is infection or not. But remember, in this instance, they will be elevated as a consequence of the trauma. So they're not as helpful. If you then decide that you're going to aspirate the knee to be able to exclude infection, this may well lead to delay in operative treatment of these patients. And that's where innovative things like the alpha defensin test, the synovial, may well be helpful in these cases, because then you avoid that delay in surgery. Classification systems, there are a few classification systems, but the one that is probably most useful, most user-friendly would be the Felix classification. This is based on work that they did on the retrospective study on 102 fractures that they had in their series. And essentially, the basis of it is one, where they looked at a major anatomic pattern and then subcategorize that. So with the major anatomical pattern, you've got fractures of the tibial plateau, which would be 1, fracture adjacent to the stem 2, distal to the prosthesis, and then these here, which are quite rare, fractures of the tibial tubercle. But having said that, the subcategory is also very, very important because you need to know whether the prosthesis is well fixed or whether it's loose, because that changes the way you manage these fractures. There are other classifications, as I've mentioned, the AO classification. They have seemingly adopted the classification that was proposed by Professors Duncan and Haddad, and it is this universal classification, which at this time hasn't really enjoyed universal acceptance, and it is a classification system that is comprehensive, but probably, in my opinion, maybe not that user-friendly, certainly for tibia periprosthetic fractures. The aims of treatment in these patients, remember these patients are mostly elderly patients, they are frail patients. So Kane and his colleagues, quite some time ago in 1986, came up with what they felt was an acceptable result in these cases, but not much has changed, and I would agree that the aims remain the same. So what you're aiming for is no pain in these patients, consolidation of the fracture, some capacity of the patients to walk, and a knee range of motion of at least 90 degrees in these patients. Conservative treatment is appropriate in undisplaced fractures around a stable prosthesis, so your 1A and 1C fractures. Plate osteosynthesis, this would be in those fractures where the prosthesis is stable. And preferably, what you would want to use is you want to use a polyaxial lock in place, because polyaxial lock in place will allow you to be able to aim that screw, to be able to avoid the prosthesis, but at the same time using concepts of lock-in screws. So there are monoaxial plates that are available, but in this instance, polyaxial plates would be more preferable. And the principles would be the AO principles of fracture fixation. The approach would be either a standard approach, but more preferably a MIPO approach, because these patients are more prone to infection. Remember, there's better blood supply around the distal femur and more soft tissue than in the tibia. In terms of whether we should be using techniques of double plating or not in these fractures, this has not really been worked out. But what we know is that certainly in bicondylar fractures, in typical tibial plateau fractures, there is a place for bicondylar plating. In the periprosthetic fractures, this hasn't quite been worked out, but also knowing that the complication rates of bicondylar plating are much, much higher, including infection and also compartment syndrome. So with your type 4s, which are quite rare, treatment would include leg screws, plate, and screws. Those prostheses that are loose have to be revised. And we have access to a lot of prosthesis types, but in general, the fixation has to be in the metaphysis for these fractures. So you would have to use stemmed prosthesis. If the collateral ligaments are involved, then you've got to go with a hinge. And there are instances where there's such poor bone stock in the proximal tibia that you've got to go with one of these. And in terms of your bone defect management, you can either use trabecular metal cones, bone graft, or structural bone graft. So with these are some examples. So for that sort of fracture, we went for a stemmed implant, cemented stem. And for two-type fracture, we, in this instance, decided to go for a hinge with also a cone in this instance. The Felix classification, it does have some limitations. So, for example, this patient, where quite clearly you can see that there's a fracture of the tibial plateau at the back there. What was surprising is the patient was also complaining of pain in the distal tibia, and closer inspection of the distal tibia showed that she actually had a fracture in that area, almost like a stress type fracture. And the Felix classification would not necessarily be able to account for this unless if, again, you treat these as two different fractures. And this is post-op x-ray on the same patient. So in conclusion, Mr. Chairman, the incidence of tibial periprosthetic fractures is increasing because we are seeing patients that were done 10, 15 years beforehand that are now presented with these periprosthetic fractures. It is important that any doctor who deals with this type of pathology is familiar with bone fracture fixation principles and revision total knee replacement techniques. And the aim ultimately is to get the patient mobilizing as quickly as is possible. Thank you very much.
Thanks, Lipalo.
Thank you.
Those patients where you get an intraoperative split fracture, would you go for a stem on all those patients or just put a few screws across? How would you manage it?
Well, it depends on where the fracture. So with the type 1 fracture, a lot of the time, because we use cemented implants, that should be sufficient. But if you go with type 2, type 3 fractures, then yes, in those instances, then you've got to convert that to a stem, because what you want then is metaphyseal fixation.
Yeah, I think something you perhaps didn't mention, it's quite implant specific, like the cylindrical type of stems on standard implants generally don't have this problem, where the conical ones are much more prone to it in sclerotic hard bone.
Correct, yes. So again, it's something that I also mentioned, that the incidence is much higher than we ascribe it to be, because a lot of the times it's one of those cases where you're doing a revision knee replacement where you're not even aware that you've caused a fracture, and when you look at the x-ray you can see that little bit of cement that is creeping out of the stem, and that indicates that there must have been a fracture at the time of the operation. So the incidence is much, much higher than what we believe it to be.
It's probably also using all of these cones and sleeves and things now. Usually it's quite sclerotic bone.
Yes.
So you've got to be really careful about preparing the beds for those, because it's very easy to split them.
No, that is true. And you've got to get a bear as well, have a bear available so that you can really clean that area and create enough space for the cone to be able to sit properly.
Any questions from the floor? Got a very quiet floor today. Yeah.